Welcome to our comprehensive lecture on scabies, designed especially for dermatology physicians. Let's dive deep into everything you need to know. Scabies is a global dermatological challenge caused by the mite Sarcoptes scabiei var. Hominis. With millions of cases worldwide, prompt recognition and treatment are crucial to control outbreaks and reduce morbidity. Scabies is especially common in crowded environments and resource-limited settings. Young children, institutionalized elderly, and immunocompromised patients face higher risks. Recognizing these risk groups helps clinicians prioritize screening and prophylaxis. This microscopic parasite literally eats your skin. The female mite is attracted to the warmth and odor of human skin. Using its mouth and special cutting surfaces on its front legs, it burrows into the host. Once inside, the parasite continues to burrow through the skin, leaving secretions and waste in its way. It's these secretions and waste products that trigger the body's immune response, causing inflammation and rash. The scabiei life cycle begins when a female mite burrows into human skin. Once inside the skin, the female lays eggs. The eggs hatch and then become adult mites. The adult mites return to the skin surface to look for mates. And when the female successfully mates, the life cycle is complete. Adult mites will often seek out a new host. They do this by hitching a ride on sheets, linens, or through skin-to-skin contact. Look for intense nocturnal itching. Classic burrows, papules, and vesicles. Crusted scabies presents with widespread hyperkeratotic plaques and is highly contagious, often in immunocompromised patients. Infants may have lesions on the head, palms, and soles. Bacterial superinfection can complicate untreated or severe cases. Diagnosis hinges on recognizing the typical distribution of lesions and confirming the presence of mites or eggs via skin scraping. Dermatoscopy reveals the jet with contrail sign. Always consider scabies in patients with unexplained nocturnal pruritus, especially if close contacts have similar complaints. Permethrin 5% cream is first line. Instruct patients to apply from the neck down and leave it on overnight. Repeating in 1 week. Sulfur ointment is preferred for very young infants, while benzyl benzoate and crotamyton are alternative topical agents. Ivermectin orally at 200 micrograms per kilogram is highly effective for crusted scabies, large outbreaks, or cases refractory to topical therapy. Repeat in 1 to 2 weeks. Use caution in patients under 15 kilograms or pregnant women. In crusted scabies, combine oral ivermectin on days 1, 2, 8, 9, and 15 with daily topical permethrin. Keratolytics may help remove thick scales. Treat all contacts to halt transmission. Residual itch can persist for weeks. Manage with topical steroids or antihistamines. Launder all bedding and clothing used within 72 hours before treatment. Seal non-washables in plastic bags for at least 1 week. Reassess patients in 1 to 2 weeks. If symptoms persist, consider retreatment. In institutional outbreaks, treat all residents and staff simultaneously, even asymptomatic carriers, to prevent reinfestation. Remember to apply topical medication thoroughly, educate patients on compliance, and treat close contacts. Combination therapy helps in severe or resistant cases. Address persistent itch with supportive measures. Thank you for watching. We hope this lecture empowers you to diagnose and treat scabies more effectively. Please like, share, and subscribe for more in-depth medical lectures.